My name is Professor Mirco Herbort from the OCM clinic in Munich, and I'm specialized in knee surgery, and I do a lot of sports trauma cases with ACL, PCL and multi-ligament reconstruction. In general, there are two groups of my patients when I use the internal brace. On the one hand, the PCL patient, and in every case of my PCL patients, I use an internal brace. And on the other side, my ACL patient. And I think there are just some special cases, some special problem cases when I use the internal brace. So the PCL is a big problem in ligament reconstruction, and as we know, we have to protect our graft in the first phase of remodeling, of healing. And in Germany there is a big history about very restricted rehabilitation, and we use a brace, we use a PTS brace, and we use a very low rehabilitation and a restricted range of motion. But I think we could be a little bit more aggressive if we use an internal brace, and I have the experience that I have a better result and a lower tibial translation after using internal brace in PCL reconstruction. So I think there are a lot of interesting cases and problem cases in the ACL, and we have learned a lot about these cases. For example, slope and hyperextension patients. For example, if we have a pathological slope more than 12 degrees, we have learned there's a high risk of re-rupture. And the problem is, I cannot motivate a patient, especially in a primary case, to do an osteotomy when he has just an ACL rupture. So I think in these cases, with an internal brace, we can protect the ACL on the high loading caused by the pathological slope of the posterior slope of the tibia, and then maybe we don't have this big problems with re-ruptures in the slope case. Another issue group are the hyperextension patients, hyperlaxity patients. And these patients, we usually use a very restricted rehabilitation, but I think this is a good option to protect the ACL for hyperextension and hyperlaxity, because maybe this is very comparable to the PCL, because we have a first phase around 2 months where the ACL has to be protected. And then we can be a little bit more aggressive if we have a protection by an internal brace. So I come to internal brace over a knee luxation. So the first time we used internal brace in knee luxation patients. So we did open repair of the ligaments, ACL and PCL, and we did an internal brace. And very interesting was that we started to do a very active rehabilitation. So the patient was allowed to do full weight bearing, and we start not to use a PTS brace, for example. And this is the highest or the biggest problem case with the highest laxity and instability. And even these cases we could stabilize with an internal brace. And this is why I really believe in stabilization by an internal brace in a single ligament case. So at the beginning I was wondering, maybe we have a disturbance of the remodeling of the graft. But in my PCL cases, I couldn't see any problems with the remodeling, with the healing of the graft, although maybe we have a little bit unloading of the graft. But I think it's just only a protection of the PCL, and there's still a loading on my graft during range of motion. We have to protect our graft in specific cases. We have to protect them in PCL, especially with a low slope. And we know that from Andreas Weiler's publications. And we have to protect our ACLs in a high slope situation for the ACL, we know from Pinchevsky. So therefore we have data about problem cases, and I think internal brace could be the solution.